A pleasant day to all of you. I am Dr. Abby Jennifer Tamayo Tolentino, and we are still discussing the last element of instructional design, which is student evaluation. But the focus of this presentation is on the different methods of assessment. We will start off with written assessment, to be followed by clinical and performance-based assessment, portfolio, peer, and last would be self-assessment. Our outcome for this presentation is for us to be able to describe varied assessment methods, apply the principles of OBE in planning course assessment, design an assessment plan for the assigned course, and integrate assessment concepts in the design of an assessment plan. Written assessment is well established and widely used to assess the acquisition of expected level of knowledge and its application to clinical problems. Written assessment has three elements. The first element is the stimulus or the task that necessitates a learner's response. It could be in the form of a question or short statement. For example, in which of the following pathologies does a patient typically present with weight loss and an increased appetite? Or list the three key therapeutic options in the management of a patient with hyperthyroidism. Stimulus or task can also be in the form of a statement or question accompanied by diagrams or charts. For example, in the diagram, which structure is labeled A? Stimulus can also be in the form of a short clinical scenario with a patient's presentation, followed by a question. The second element is the response of the learner, which can be categorized into constructed response or production questions and selected response or recognition questions. Constructed response items um, requires the students to provide a long or short narrative or very short answer in response to the stimulus. Examples would be essay and identification. Selected response or recognition questions require the examinee to make a selection from a range of options provided. Examples would be multiple choice questions, true or false, and extended matching questions. The last element of written assessment is the assessment of the response. The response may be scored automatically by a computer as correct or incorrect, as in multiple choice questions in which there is an agreed correct answer. This also applies to short answer questions in which the expected answer is limited to a few words. In this case, agreement has to be reached with regard to alternative wording and spelling that is acceptable. Assessment of response can also be done by an examiner, especially in a constructed response questions based on a holistic impression of the student's response or with an agreed structured marking scheme. There are different types of written assessment. So the first is essay questions. The essay can assess the learner's general understanding of the topic. It can also test higher level skills including synthesis, organization of information, analysis, problem solving, and evaluation. Written communication skills can also be evaluated by essay questions, which is often not tested by other written assessment methods. Although written communication skills can be assessed by portfolio assessment, reflection paper, written reports. Essay questions can also assess aspects relating to attitudes and medical ethics. The disadvantage of essay, however, is that the content area sampled is small compared to an multiple choice examination, and the scoring of the questions is subjective and time consuming. Short essay questions are designed to sample a wider range of content than essay questions, but it has the same disadvantage in terms of scoring, which is subjective and time consuming. To address subjectivity of scoring, grading rubrics may be used. This is an example of a grading rubric that I constructed for checking essay questions. The stimulus is economic stability is one of the social determinants of health. In 2 to 3 sentences, explain its association with healthcare access and utilization of health services. Since this is a short essay question, the response format is constructed response. And then the assessment of the response can be performed by an examiner based on an agreed structured marking scheme like this one. Other types of written assessment include very short answer questions, which sample a wider range of content compared to the other two. In this type of examination, the learner responds to the question in one, two, or a limited number of words rather than selecting from a list of choices as in an MCQ. This is what we know as identification. Answers can be automatically marked using a computer program, but agreement must be reached first regarding the acceptable answer. This is a more valid assessment and can reflect the clinical decision process without the queuing inherent in MCQs. It eliminates the possibility of answering an item correctly simply by chance. But it is also more challenging, which provides better discrimination than the MCQs. Multiple choice questions, undoubtedly, among all written examination formats, can sample the widest range of a student's recall of knowledge and understanding. And MCQs can do it objectively because there is just one correct or best answer. The downside of MCQs is not in the scoring or marking of the responses, but the construction of the test questions, which requires skill, effort, and time. Care is needed in constructing MCQ items such that any cues leading to the correct answer should be eliminated so that the possibility of answering an item correctly simply by chance is therefore reduced. Another disadvantage of MCQs is that most often the assessment of higher order thinking cognitive skills like apply, analyze, evaluate, and create can be limited and limiting. But there has been a move to introduce greater authenticity to the MCQs through the use of clinical scenarios in the STEM or stimulus. And this requires more skills and effort and time in test construction. True or false questions also fall under multiple choice questions or MCQs. Lastly are the extended matching questions. The MEQ is a useful way of testing clinically relevant knowledge and provides an alternative to the standard MCQ. It consists of a list of about 20 options relating to a theme or topic. For example, a list of drugs, diseases, laboratory tests, symptoms, or pathologies. The lead in STEM or stimulus can be in the form of a patient scenario. Following the stimulus, the student has to select the most appropriate answer from the list of options. With these many options, the level of queuing is minimized. One, two, or more questions can use the same list of options, also effectively reducing the time taken to produce the questions. Clinical and performance-based assessment assess the clinical and practical skills of examinees and how their knowledge is applied in the clinical context. It is also being used to assess attitudes, behaviors, and soft skills that are important in patient care. A range of methods have been used to assess the student's competence in a controlled clinical environment and how they perform in the workplace or real clinical situation. Performance-based assessment assess the higher two level of clinical competence. The most common performance-based assessment is simulation, especially if the students are still in their early years in the medical program. The design of the simulation would be dependent on the task or skill that should be performed or observed. The grading will require use of checklists or grading rubrics, and the criteria or standard of performance would be determined based on whether it is the process or the product or both that will be evaluated. Objective Structured Clinical Examination or OSCE was introduced in 1975 in response to the criticisms about the reliability and validity of the traditional examination of clinical skills. And now OSCE is recognized as the gold standard for the assessment of clinical competence. So what happens is that students rotate around a series of stations at a predetermined time interval, with each station focusing on one or more aspects of competence. This diagram is the original version of OSCE, which was first conducted by Dr. Ronald Harden. Students move around 18 testing stations and 2 rest stations in a hospital ward. Each station was 4 minutes and 30 seconds long, with a 30 seconds break in between stations. Each station tested a single competency. For example, Station 5 evaluates neurological examination of legs. Station 13, history taking of patients with hematuria. So those are the examples. The total examination for these 20 stations was 100 minutes. Over time, OSCE was developed further, and now it may typically last for 2 hours and have a maximum of 24 stations with 5 minutes allocated for each. This allows for wide sample of competencies to be assessed. Alternatively, OSCE may have fewer stations with longer time allotted for each station, but the former format is preferred because it increases reliability and validity of the examination. Which in the first place is the reason why OSCE emerged. OSCE operates on the principles of objectivity and standardization. OSCE's objectivity arises from the standardized scoring rubrics and the same trained examiners asking the same questions to every candidate. OSCE also provides structure to the examination through the standardized station design, assessing a specific clinical task which is blueprinted against the curriculum. OSCE also uses a test blueprint despite it being used to assess clinical skills because table of specifications or test blueprint ensures validity of the examination, measuring what it intends to measure. The standard station design, standardized scoring rubrics, and the trained examiners not just only account for standardization and structure, but more importantly, the reliability of OSCE. So to eliminate inter-rater variability that affects reliability of the method, examiners are trained prior to the actual testing. The downside of OSCE is that it requires more preparation. The development of the stations, the construction of the rubrics, the training of examiners, and standardized patients if they are to be used. All of these require skills, time, and resources. OSCE is resource intensive because it requires multiple examiners and standardized patients also. For workplace-based assessment, we have mini clinical evaluation exercise or mini CEX and DOPS or direct observation of procedural skills. In a mini CEX, the learners are engaged in an authentic workplace-based patient encounters, maybe in the OPD, inpatient setting, or emergency room. While the student is engaged in the patient and the task to be done, the examiner watches or observes and then grades the student using a grading rubric. The encounter usually lasts for about 15 to 20 minutes. This method has the advantage that it ensures that the clinical skills of the trainee are observed by the clinician or preceptor in the workplace setting and that feedback is given to the learner. DOPS or direct observation of procedural skills is a variation of the mini CEX, focusing more on skills, on procedural skills. In both strategies, the trainee selects the timing of assessment. In mini CEX, trainees also select the patients, while in DOPS, the trainees select the procedure to be assessed from a prescribed list. Case-based discussion can also be used in a workplace setting. So what happens is that the trainee selects several records, medical records, in which they have made entries regarding patients they have seen recently. The examiner selects one patient record and explores aspects of it with the trainee. The dimensions may include clinical assessment, investigations and referrals, treatment, follow-up, future planning, professionalism, and overall clinical judgment. And then each dimension is scored using a grading rubric. Case-based discussion can also be used for assessment of application of knowledge, decision making, ethical issues, as well as medical record keeping. Multi-source feedback or 360 degrees evaluation is the assessment of trainee in the real-life practice context through a systematic collection from a number of individuals who are in a legitimate position to make judgments about the trainee's performance. It could be the patients or other members of the healthcare team. In this way, different perspectives are brought to bear on the evaluation of the learner. The aim of multi-source feedback is to provide a fair and balanced view of the learner's behavior and abilities, including communication skills, leadership, teamwork, punctuality, reliability, and other aspects of professionalism. A portfolio can also be used in the assessment of a student's clinical competence. Portfolio is a collection of evidence demonstrating that learning has taken place. It assesses what the learners do rather than what they know in written clinical examinations. The evidence are collected over a period of time, so it really demonstrates that learning has occurred since portfolio assessment can depict the progress of the student. Portfolios may include evidence of the practical procedures carried out by the learners, video records of clinical experiences, evaluations of performance in written assessments, and reports by preceptors on the student's clinical attachments. Multi-source feedback from other members of the healthcare team and patients may also be included in the portfolio. The portfolio also include the students' reflection on their learning experiences and how these contribute to the achievement of the learning outcomes. Portfolio offers a number of advantages. First, it can be used to assess outcomes and competencies where other assessment tools have been less successful. For example, assessment of skills necessary for lifelong learning, such as self-assessment, reflection, and adoption of appropriate learning strategies. It can also contribute to the assessment of students' attitudes and professionalism. Portfolio can provide an overall and holistic view of a student's competence since it includes evidence that are collected over a period of time. It can also include a range of quantitative and qualitative evidence, leading to triangulation of different sources that may help examiners or teachers make a comprehensive and reliable interpretation of students' achievement. Portfolio can also be a powerful tool for both learning and assessment because it focuses the student's attention on the learning outcomes expected. The reflection paper at the end can include reflections on the relevant applications of basic sciences to clinical practice. Portfolio assessment reinforces a student-centered approach to the curriculum, with students being given greater responsibility for their own learning, thereby increasing learner involvement. And lastly, it can be used to assess growth over time and can provide a useful method to identify students who are experiencing difficulty so that timely remedial assistance may be done if required. There is an increasing attention to peer assessment because it is particularly valuable in assessment of attitudes, teamwork, and leadership skills. Meanwhile, the ability of doctors to assess their own competence is an important learning outcome since it provides insights into their own limitations and competencies. It can also help identify their learning gaps and update their knowledge or skills as necessary. Self-assessment is increasingly becoming an essential skill parallel to the emerging trends in medical education, like the move to self-directed or self-regulated learning, engagement of the students as partners in the learning process, recognition of the importance of the students reflecting on their own progress, emphasis on assessment for learning, use of simulation where students can practice in safe environment, and approaches such as flipped classroom where the learner has to study on their own prior to attending the face-to-face session. Asking the learners to evaluate their performance further leads to greater motivation and improved performance, but conducting self-assessment or implementing self-assessment is not easy. The major issue with use of peer and self-assessment is the unreliability of assessment. Should this be kept formative in nature, or can it be considered as part of summative assessment? If this remains formative, will the students do it, knowing that it will not contribute to their grades? If it will be included as summative assessment, how much of the total grade should be allotted for this? If it's too low, maybe the students will still not do it even though there is a numerical value attached to it. Kung mataas naman, baka dayain ng students yung assessment nila, defeating the purpose of peer and self-assessment. So these are the main concerns when using these forms of assessment. So with that, we have introduced the different types of written assessment and its elements, clinical and performance-based assessment, the importance of portfolio assessment, the value of peer and self-assessment, and the issues related to them. This is the last presentation for this series. So thank you for watching until the end.